We are done discussing what heart failure is, even the signs and symptoms, symptoms of heart failure, and the body's response to the deficiency in oxygen, and the pathophysiology of cardiac performance. So I think we ended there. And we are now sa basic pharmacology of drugs used in heart failure. So let us start with digitalis. Again, digitalis, that's the genus name for the family of plants that provide most of our cardiac glycosides. Okay, cardiac glycosides na medically useful, especially the digoxin. Okay, especially the digoxin. They come from digitalis. Now, we have two types of digitalis. The purple foxglove, ang scientific name is the digitalis purpurea. And the white foxglove, the scientific name is Digitalis lanata. So, but nevertheless, they are from a family called Digitalis, and dinha nato ginakuha ato ang mga cardiac glycosides. So, pag sinabing glycosides, di ba, they are phytochemicals, and cardiac means ang effect nila is on the heart. So, let's talk about digoxin. This is the medically useful na cardiac glycoside. The brand name in the market is Lanoxin. So again, it's a cardiac glycoside or cardenolides obtained from Digitalis lanata. Remember, we have two types of Digitalis class here, the purpurea and the lanata. And para ma-clarify, the lanata will give us the digoxin. A brand name in the market is Lanoxin, while the purpurea will give us the digitoxin. So pareha sila ng effect class. They are positive inotropic agents, meaning sa inotropy or inotropic agent, meaning they will increase the force of contraction sa heart. Again, they will increase the force of contraction sa heart. Pareha silang effect. However, why do we use digoxin more than the digitoxin? From the name itself, digitoxin class, digitoxin is considered toxic to our body because of its very high na half-life. Again, very high na half-life. The half-life for digitoxin is approximately 90 hours. So 90 hours magstay ang drug sa body. And for us, class, that is already toxic. The longer the drug stays in the body, the more toxic it gets. So that is the reason why we use digitoxin more than the digoxin than the digitoxin. So however, though our main source of digoxin is the Digitalis lanata, we can also find this one in other plants. Dili ni sila digitalis ha, pero other plants ni sila where we get our digoxin. The oleander, the lily of the valley, and the milkweed. Now, let's talk about the mechanism of action of our digoxin. Paano niya ini-increase ang force of contraction? So, this time, pag sinabing mechanism of action ni digoxin, it is a sodium-potassium ATPase inhibitor. Wagid na siya ang always gina-ask na mga question pag abot sa mechanism of action of digoxin. Unsa ba iyahang receptor? The receptor is the sodium-potassium ATPase, but it is an antagonistic nga action ha. Antagonistic meaning inhibit niya na. Now the question, is sodium-potassium ATPase an enzyme? No.
No.
Pump siya. Okay, pump. It's a pump class that will exchange sodium and potassium. Okay, so if the digoxin inhibits this pump, the result will be reduced in calcium expulsion and increased calcium stored in the sarcoplasmic reticulum. So we are talking about the heart muscle here. Pag i-inhibit si sodium-potassium ATPase, the result will be more calcium inside the muscle cells of the heart. And remember, since we are talking about muscle and muscle contracts, dapat mag-contract na siya with the help of calcium. So, mo na siya class nga, if calcium is being stored inside the cell of the heart muscle, there will be more contraction. And that will result to positive inotropy. There is increased force of contraction in the heart muscle. So, to illustrate this one, let me just unshare ha, because I think I have a video about the mechanism of action of digoxin. Let me look at it first if I still have a copy. Sa akong desktop. Yeah, I still have, pero I think murag wala ni siya murag wala ni siya sound. Wait lang ha. Okay, so makita this one. So please look at the video on the screen, class, para masabtan ninyo how digoxin works. Paano nagkaroon og activity na ma-store si calcium inside the cell na ang iyahang gi-inhibit is si sodium potassium ATPase. The pump that will exchange sodium and potassium. So again, I think wala ni siya sound. So ako na lang ang mag-istorya. Okay, so again, this is the heart. We have here the heart muscles, the cells sa atuang heart. Siyempre, nag-contract na siya ha. Nag-contract na siya. Now, on the surface of the cell of the heart muscle, we have the so-called sodium-potassium ATPase or the sodium-potassium pump. So, unsay trabaho ana niya? It needs ATP, that is why it is called sodium-potassium ATPase, para mag-exchange si sodium ug si potassium. So, take note of the ratio. Take note of the ratio. 3:2. Si 3 na antukin. 3 ka sodium ang mugawas, 2 ka potassium ang magsulod. So with the help of ATP. Now here comes digoxin. Digoxin will bind to the sodium-potassium ATPase, therefore inhibiting the exchange of the sodium and the potassium. However, paspas kayo, yung kapas. Gusto tayo mag-voice over. Now, pag-inhibit niya sa exchange ni sodium and ni potassium class, syempre, remember atong mnemonic sa chemistry na piso? Potassium in, sodium out. Diba mo na siya? And para kumpleto, mag-piso. Mag-piso. So si magnesium and si potassium dapat na sila sa sulod sa cell. Magnesium, potassium in, sodium and calcium out. So that is the reason why na naga-exchange permi. If sodium is inside and potassium is outside, they have to exchange. Kailangan si sodium mugawa, si potassium musulod. So dito sila moagi kay sodium, potassium, ATPase. Now, kag-inhibit naman siya ni digoxin. Ang mahitabo manggudaan ni class, the sodium still needs to go out. Kay extracellular ion man na siya. So mag-shift na iyahang action dito sa another exchanger or another pump. Kay na block naman nato si sodium potassium ATPase. So let us continue. Si sodium, mangita siyang pamaagi class nga makagawas siya. So, diri siya karon mo makipag-exchange kay calcium. Kay natay ginatawag og sodium-calcium exchanger. Again, sodium-calcium exchanger. Thus, there is still 3 sodium na maglabas using this pump and isang calcium ang papasok. Therefore, calcium has entered the cell and it can help in the contraction of the heart muscle. That's how digoxin works, class. Any question? Nasabtan to? Or wala na sabtan? Ang trabaho ni digoxin nganong ang iyahang gi-inhibit kay ang sodium potassium ATPase, but the result is again the increase of calcium inside the cell that will help in the contraction. Kasi that is our problem with heart failure. We have problem with the contraction of the heart. So medyo nagahina ilahang contraction na so that they cannot deliver enough oxygen sa body. So what will be the effects of our digoxin? Syempre there is increased cardiac contractility because of the increase of calcium inside the cell, that is called inotropic effect, and there will be cardiac parasympathomimetic effect. Parasympathomimetic, dili simpa ha, parasimpa. And what are those effects? The slowed sinus heart rate, meaning class digoxin can increase the force of contraction, but it can slow down the heart rate. Again, it can slow down the heart rate or it can slow down the atrioventricular conduction. I hope humana mo ni Christine with the arrhythmia, kay gipasan ako sa iyaha ang arrhythmia. And I hope you have learned there na pag maingon kag arrhythmia, our heart class, ang iyahang rate, ang iyang pag-contract is dependent sa electricity na gina-provide sa ato ang pacemaker. So, pacemaker from sinoatrial node going to the atrioventricular node, ang electricity mag-travel na siya. But since class, kanang electricity nga ginatawag dira, ang involved are the ions, sodium, potassium, calcium, and other ions in the body. Now, since the action of digoxin is this one involves ions, no, nagdaghan ang calcium, mukusog ang contractility sa heart, pero nagahinay iyahang heart rate. Kasi most of the time, it's actually sodium that will start the, what do you call that? Action potential. The action potential. Si sodium ang mag-start, ana. Humana mo ni Christine og arrhythmia, wala pa? Or nakasugod na? Ha? Wala pa?
Mag-class 4 pa kami mamaya.
Okay, so di ba sa start sa inyong discussion sa arrhythmia na ay ingani, we call this the action potential. And the action potential starts with the help of sodium. And since for digoxin, the sodium will go out the cell, maglabas siya sa cell, muna siya ang ginaingon class nga mag-slow ang heart rate. Pero mo increase ang contractility because of the calcium influx. Magsulod si calcium sa cell. So I hope nasabtan ninyo na. Now again, the cardiac effects increase cardiac contraction by increasing free calcium concentration through the following. Number 1, increase in intracellular sodium concentration because of the sodium-potassium inhibition. Inhibit niya si sodium-potassium ATPase, tapos pagkahuman mo daghan si sodium, but sodium needs to go out. That is why dito siya makipag-exchange kay calcium. So we call that sodium-calcium exchanger. Sodium will go out, calcium will go in. Take note of the ratio ha for sodium-potassium ATPase, si 3 na antukin. 3 na, 3 ka sodium ang mugawas. And then antukin, 2 potassium ang magsulod in. Okay, 3 sodium, 2 potassium. But for the sodium-calcium exchanger, it's still 3 sodium but 1 calcium na magsulod. Okay, so clinical applications now of our digoxin. We can use this for chronic symptomatic heart failure. So this will become a maintenance drug for them to aid in the contraction of the heart of the patients with heart failure. And we can also use digoxin for rapid ventricular rate in atrial fibrillation. So digoxin class is also used for arrhythmia. Atrial fibrillation is one type of arrhythmia. It involves the atrium of the heart and there will be irregular heartbeat. And then again, we call this rapid ventricular rate in atrial fibrillation. So at the end of the slide of the antiarrhythmic drugs, you can still encounter digoxin. And you will see there the difference between the dose of the digoxin used for heart failure and the dose of the digoxin used for arrhythmia. So dito na lang sa part na i-discuss ni Christine ang katong sa end part sa antiarrhythmic drugs. Now for the toxicity. If you are going to ask me, is digoxin toxic? Yes, this is very toxic since diba, it involves the heart. Or don't give me the nausea and vomiting because that is true for almost all of the drugs. If you're asked what is the first sign of digoxin toxicity, it's the gastrointestinal disturbance, meaning if you can, the patient can have diarrhea, or again, we just call it GI disturbance. Now, aside from that, the life-threatening, again, the life-threatening na toxicity ng ating digoxin is the cardiac arrhythmia. So let me write this one kay tinatanong ito sa board exam. Ito yung life-threatening, though digoxin is a drug for the heart, but take note that it can affect the heart rate. So the patient may experience arrhythmia, and arrhythmia class is always life-threatening kasi nag-irregular na ang heart rate sa patient. Aside from that, digoxin can also cause disorientation and hallucination, thus it also has effects sa CNS. And this one is also a board exam question. One sign of the toxicity of digoxin is visual disturbances. The patient may experience blurred or yellow na vision, mura gihepa ang iyahang tanaw, ang iyahang vision class. Ang tanaw niya sa iyahang palibot is yellow. So we call this one medically as xanthopsia. Okay, xanthopsia ang tawag ana medically. And lastly, just like our spironolactone, digoxin can also cause gynecomastia. Okay, meaning sa gynecomastia?
Po ang breast sa sa men.
Okay, very good. Magdako plus ang mag-enlarge ang breast sa especially sa lalaki, pero tama man to siya isa lang ka side. Mostly isa lang gid siya ka side. So mo na siya class ang toxicity ni digoxin. Now, digoxin class is a very toxic drug. It has a very low therapeutic index. Therapeutic index. So, di ba ang therapeutic index is the ratio between the effective dose and the toxic dose. So kung mingon kag very low, the difference between the effective dose and the toxic dose is very small, na if ma-double dose nimo siya, mahimo na siya toxic. And take note of the signs of toxicity. So in the market, the dose, if I'm not mistaken, the dose of digoxin in the market is 25 micrograms only. It's a very small tablet. Naka-loose tablet ni siya. So if the patient will not buy the whole bottle, naka-bottle man gud siya, gina-refill siya. I mean, gina-repackage siya sa mga pharmacies, nilalagay sa cellophane, but take note na kailangan nyo siya lagyan ng correct label. The name of the patient, the age, the name of the drug is very important, and the quantity also kung pila imuhang gi-dispense sa ilaha. The name and the dose of the drug. Now, since this one is an example of a drug with a very low therapeutic index, kailangan siya class i-monitor. So, mo ni siya ang drug nga pirmi gina-monitor sa mga clinical pharmacists, especially if the patient is admitted. Kasi, since the action involves the ions, di ba, sodium, potassium, ATPase, so kailangan i-monitor ang patient when it comes to their electrolyte kung nag-balance bagihapon or basing nag-experience na sila electrolyte imbalance, kasi it will dictate whether the digoxin will be effective or magkaroon og toxicity for digoxin. So number 1 here na interaction, we have potassium and digoxin. So kana si potassium and si digoxin class, kalaban na silang duha inside the body. They compete with sodium potassium ATPase, because potassium really needs to go inside and sodium needs to go outside. Now here comes digoxin, so mag-compete na sila with each other in the binding kay sodium potassium ATPase. Therefore class, if the patient experiences hyperkalemia, mutaas ang iyahang potassium, this will result in the reduction sa effect ni digoxin. Mag-reduce yung effect kay pag mayngon magugkag competitive inhibition, madaog lang ang tambal basta mas daghan siya. Okay? So for example, kani mas daghan si potassium, so mudaog yun siya when it comes to the binding in the sodium potassium ATPase. So mag-reduce ang effect ni digoxin. Atong another problem is if mag-hypokalemic pod ang patient, magbaba iyahang potassium level. Example, nag-diarrhea ato ang patient class, di ba? Pag mag-diarrhea ka and then you will experience electrolyte imbalance, pwede nga mo baba imuhang potassium level. And since baba imong potassium, walay ka-compete si digoxin when it comes to the receptor, then it may facilitate the action of digoxin or it may lead to toxicity. Again, kay wala na siya kakompetensya. So isa ni siya sa gina-monitor nato as pharmacist or even katong mga naga-clinical pharmacy. You can also proceed sa Clean Farm class. 1 year lang man na siya. Si Ma'am Mabel lang ang Clean Farm sa doctors. Ay, appeal si Cristel ata. Pero dili ata ninyo teacher si Cristel. Pero nindot sad kasi it will supplement your knowledge about drug therapy and unsa ang mga interactions niya. Especially if you will work in the hospital and mag-abroad mo. Clean Farm is very useful. So ako kay wa man koy balak mag-abroad, wa pa gyud koy balak mag-hospital pharmacist. So mo na nga wala gyud ko ni eskwela og Clean Farm. So depende na siya sa inyong goal. Hindi kay akong goal kay diri man sa side sa academe, mo nang nag-masters ko. Kay diri ang ako ang dalan. So maghuna-huna mag-unsa ba inyong gusto. Now, let's move on with another ion, the calcium. So, calcium facilitates the toxic action of cardiac glycosides by accelerating the overloading of intracellular calcium store. So, our goal for digoxin is to increase calcium inside the cell. Now, if the patient experiences hypercalcemia, daghan na siya daan og calcium tapos padaghan pa gyud nato siya inside with digoxin, toxicity gyud na iyahang gawas. Okay, pagdaghan og calcium. Now how about magnesium? Class, inside the body kana si calcium ug si magnesium kalaban na silang duha. Okay, most of the time if calcium will increase, magnesium will decrease. So mao na ang nakabutang diri opposite to the effect of calcium. So kung hypercalcemia, di ba mag-toxicity. So kung opposite sa calcium yung effect, meaning na pag mag-hypomagnesemia ang patient, what do you mean by hypomagnesemia? Magbaba iyahang magnesium, that's the time magkaroon og toxicity ni digoxin. Okay, when there is hypomagnesemia, most likely the calcium also will go up. Laban na silang duha sa sulod sa body. That is why class, pag nakay calcium toxicity, ang antidote nato kay magnesium. And then, if there is also magnesium toxicity, ang antidote nato kay calcium. Okay, take note of that. Question so far about digoxin. Kaya mao gid na siya ato ang main drug for heart failure. Asa dapit dito ang wala na sabtan? Or nasabtan to siya? Sabtan? Okay, so let's move on. We have other positive inotropic drugs also used in heart failure. Take note, they are classified as inotropic agents, meaning they can increase the force of contraction. So let's start with ISTAROXIME, which is class an investigational drug only. Wala pa ni siya class na human ang iyahang study. We still have the phase 2 clinical trial pa siya, pero nevertheless this is being studied because they have found out that pareha sila ni digoxin that can inhibit sodium potassium ATPase. So kung ma-inhibit sa sodium potassium ATPase, this same result. There will be increase in calcium inside the cell and it can increase the force of contraction. The one advantage that they have seen or nakita nila with ISTAROXIME, this is less arrhythmogenic, meaning it can still inhibit the sodium potassium ATPase, pero unlike digoxin, dili kay siya makakos og arrhythmia. By the way, nakalimot kog sulti. Kagaina, di ba, the life-threatening class na toxicity ni digoxin is arrhythmia. Now, unsa ato ang drug for this? Na-mention ba ni Ma'am Tin unsa ang drug for the arrhythmia caused by digoxin? Na-mention ba? Wala pa. Kay murag akong pagkabalo kay class 1 yun nga anti-arrhythmia ang ginahatag for digoxin-induced. Wala na mention? Or nakalimot mo, past is past. Gihapon pa nakalimot na mi. Grabe sad. Okay, if you are asked class, especially in the board exam, our drug of choice for digoxin-induced, ang nag-cause sa arrhythmia ha kay digoxin-induced arrhythmia is lidocaine. Okay, lidocaine. Original use of lidocaine, remember, local anesthetic, but it has an anti-arrhythmic nga action, and it is our drug of choice for digoxin-induced arrhythmia. Now, another board exam question, if lidocaine is not available, what will be the next drug for the digoxin-induced arrhythmia? The next drug will be phenytoin. Phenytoin. Okay? Sige. So, marag natay mnemonics nga ginagamit for anti-arrhythmic drugs now in their classification. Sundan lang to ninyo class. Tong double quarter pounder, o lettuce mayo, and dun sa pato, I cannot remember the mnemonics. So, I hope itudlo siya ni Ma'am Tin. Marag naman to siya sa akong slide. She's using my slide, man God. Pero syempre siya may mutudlo. So bahala na siya paano niya to itudlo. So question about this, ISTAROXIME. Wala pa na share. Namaguto sa end sa akong slide. So i-share lang na niya ang mnemonics para dali ninyo matandaan kung unsang class of arrhythmia siya, class 1, class 2, class 3, or class 4. Okay? Next, another drug here is the Levosimendan. This sensitizes the troponin system. By the way, the troponin system in the heart also is active when it comes to the contraction. And it is sensitive to calcium. Mauna siya ang system na to sa heart nga sensitive to calcium. And then if there is calcium, there will be contraction. So actually, kanang troponin ginagamit po na siya og biological marker na gina-check po na siya sa dugo, nga pag taas na siya sa dugo, it also indicates that there is something wrong with the heart of the patient. So this time, si Levosimendan is, ano siya, ang iyahang action is ginapasensitize niya si troponin to calcium, and also it has an inhibitory action sa phosphodiesterase na enzyme. Again, phosphodiesterase na enzyme. So, unsa ba ng phosphodiesterase na enzyme? This is actually, wait lang. This is the enzyme that is used to degrade CAMP into AMP. So unsa man ang cyclic adeno balik triphosphate. So ATP adenosine. Cyclic adenosine monophosphate. That's the CAMP. Let me write it. Cyclic adenosine monophosphate. So si PDE na siya class. That's the enzyme that will degrade CAMP into AMP. So AMP na lang is adenosine monophosphate. Now in the case of levosimendan, this will be inhibited class so that CAMP will stay as CAMP and mag-increase siya in the body. So why do we need this substance in the body? Because CAMP class is used as vasodilator in the body, and at the same time, to some cases, it can also increase the contraction of the heart. So that is the reason why isa pud na siya ka-target sa mga drugs sa ato ang body kanang enzyme na phosphodiesterase. So that's one of the target of levosimendan. And then we have the BIPYRIDINES. We only have two drugs here, the inamrinone. Dati, this is commonly known as amrinone only, pero ngayon, this is called inamrinone na. And then we have the milrinone, the brand name in the market is Primacor. So, under na sila sa BIPYRIDINES, and they are also considered as positive inotropic agents just like the digoxin. But sa mechanism of action nila, just like the levosimendan, ang target gihapon is the phosphodiesterase enzyme. To be specific, the PDE3, phosphodiesterase type 3 enzyme, inhibit na niya. So that CAMP will not be broken down into AMP, na ay daghang CAMP in the body that will lead to vasodilation and will lead to the increase in the contractility. So kailangan po nato ang vasodilation when it comes to heart failure class para pag mag-pump ang heart og blood, the blood vessels can accommodate the blood, dili siya mag-resist kay naka-dilate siya. So that's how the BIPYRIDINES work. Inhibitor sa phosphodiesterase type 3 enzyme. Now, what are the effects? Syempre, CAMP is a vasodilator. Therefore, there will be vasodilation, especially sa peripheral na mga blood vessels, and resistance will be decreased. So, pag mayroon kag resistance class, pag pump magud sa heart, sa blood, pag wala magud na nakadilate ang blood vessel, mo resist na sila sa pag-flow sa blood. So, kung ato silang gidilate, mag-lower yun ang resistance. And at the same time, there will be increased cardiac contractility. Thus, we can also use the BIPYRIDINES for heart failure, like sa acute decompensated heart failure. Kanang acute, unsay difference sa acute ug sa chronic?
Paspas lang ang acute mamawala, pero ang chronic is dugay.
Okay, parehas anang acute kidney failure o chronic kidney failure. Ang difference ana nila, pag example chronic kasi digoxin ginagamit man gud siya for chronic, so ginagamit siya for as maintenance drug para sa atong patients with heart failure. Chronic gyud iyang sakit, progressive. Hinay-hinay mag-progress iyang sakit for a longer period of time. Pamayon kag acute kanang mukalit bitaw og kaguba iyang organ, mukalit in a short period of time ikalit og kaguba para sa nang acute kidney failure, kanang example nagkaroon og injury iyang kidney, that's acute. Kay pinaabtik class nagguba din yung kidney. Ang chronic mangud progressive for a longer period of time. So kani acute decompensated heart failure, this one is sudden na magkaroon og problem sa heart, and then decompensated na dayon, meaning kulang na dayon ang oxygen sa lawas. So that's the clinical application of our BIPYRIDINES. Now, toxicity. We have here the arrhythmia. By the way, ang atong mga tambal sa heart failure class, ang ilahang toxicity ani, ilang side effect permi arrhythmia. Kasi they can increase the contractility but they can affect the heart rate. So most of the time mauwi siya into arrhythmia pag dili siya i-monitor. And then we have nausea and vomiting, given na yun na siya basta mga drugs. The thrombocytopenia. What do you mean by thrombocytopenia? Pinya is, unsa gani ang meaning pag ang ending kay pinya?
Lower ang ano ma'am, ang ang count.
Lower? Lower may ingon no?
Lower ma'am.
Okay, sige. Very good. This one is decreased and this one is increased. So for example, thrombocytopenia, thrombocytes, baba ang platelet. Yes, tama na siya, Sarah. Thrombocytes refers to the platelet. So pag mayroon kag thrombocytopenia, there is decreased level of platelets in the body. Pag mayroon kag thrombocytosis, platelets gihapon to pero cytosis means there is increased number of platelets. Okay? So that is actually due to the bone marrow na toxicity ni BIPYRIDINES and liver toxicity. So that is the reason why mas ginagamit nato si digoxin. Though si digoxin is still toxic pero mas toxic si BIPYRIDINES. So dili kay siya ginagamit for maintenance. Again, we have here the bone marrow toxicity and liver toxicity. Yeah, when your blood platelet is baba. So parehas sa dengue class. Ang symptoms sa dengue is, or ang signs sa dengue, baba ang platelet na ay thrombocytopenia. Okay? Now, let's move on sa atong mga beta adrenoceptor stimulants. Meaning, these are agonists. We're not talking about the blockers, the agonists. We only have two, the dobutamine and dopamine. So, kung balikan ninyo atong PICOL 1, we have learned na si beta-1 receptor is most likely found sa heart, and stimulating this receptor will increase the heart rate, will increase the force of contraction, or will even increase the conduction, electric conduction. Meaning, silang pag mag-stimulate sa beta-1 receptor, there is positive chronotropy. There is also positive inotropy. I hope you can differentiate the three terms. And then the conduction is called dromotropy. Okay? So positive chronotropy, inotropy, and dromotropy sa heart. So we only have two drugs again here na humanataan ni-discuss sa PICOL 1, dobutamine and dopamine. Bind na sila sa beta-1 receptor and activate the receptor. So ang pinaka-ginagamit is the dobutamine. This is widely used, most widely used. And unsa iyang effect? Katong tulong akong giingon. It can increase cardiac contractility, thus it can increase cardiac output together with a decrease in ventricular filling pressure. So there will be decrease in the pressure during the filling of blood in the heart. Now, the mechanism of action, syempre from the name of the classification itself, beta-1 receptor siya na agonist together with the dopamine. And in some cases, class, aside from binding to the beta-1 receptor, the dobutamine can also increase CAMP synthesis. So, unsa gani effect ni CAMP? Vasodilation and increased contractility of the heart. So mo nanay nakabutang diri decreased ventricular filling pressure because of the vasodilation. So para asa si dobutamine, acute decompensated heart failure. Kana ganing sudden heart attack or cardiac arrest, dinha nato na makita si dobutamine nga ginagamit. So parehas atong when I was an intern sa St. Elizabeth Hospital, mga 11 or going to 12 o'clock guro to, na natulog ako ato ba? Kaya di ba bawal man ang intern matulog, labi na basta kanang nocturnal nga duty, bawal gina siya matulog. So natulog na ko ato niya, dito ko natulog sa likod sa pharmacy, in between the pharmacy and the emergency room. So pagka alas 11, naigidala nga patient na nagkaroon og acute decompensated heart failure, heart attack lang siya kalit. Tapos I believe lang ko sa doktor ato kay syempre ang pinakaunang ginahatag jud na epinephrine gyud na ang pinakaunang ginahatag kasi mas taas man gud ang affinity ni epinephrine when it comes to the beta receptors in the heart para mo mubalik og pitik ang heart class. Pero kato naghatag sila og epinephrine tapos nag CPR pag yun. Ang next nga ginahatag is the dobutamine. Okay? So wala mo'y makita class nga dobutamine nga naka-tablet or naka-oral nga preparation. This is given as IV infusion. So aside sa sige sila inject og epinephrine, nag-connect pa sila sa linya og dobutamine. So, kana. And then we have intermittent therapy in chronic failure that will reduce symptoms. So, since this is given as IV, pwede siya gamiton sa patient with chronic heart failure, pero intermittent therapy lang. So, karon mag-administer sa linya kay IV infusion man siya og dobutamine, tapos sa sunod cycle na sa dili gid siya maintenance drug nga ginaadlaw-adlaw kay lisod pud kaayo mag-function ng patient kung adlaw-adlaw may naka-connect sa iya nga intravenous infusion of dobutamine. Now, toxicity na mention na nako class ang mga drugs nato for heart failure ang ilahag yung toxicity is arrhythmia. Okay? Because of the increase also in the heart rate when you stimulate the beta-1 receptor, it will lead to arrhythmia. Mag-irregular na iyang heartbeat. Okay? Or yung heart rate. Now, drug interaction, dobutamine can be additive with other sympathomimetics. Additive. Mo na ko example gaina. Aside sa epinephrine, nag-connect sila sa linya ug dobutamine. I-add siya just to help the heart of the patient na mo-beat ulit. Kaya pag nag-heart attack kay nagahinay naman na iyang beat, padulong na mawala. So, gina-add lang siya, additive. Next, we have the dopamine. The same mechanism of action with dobutamine, the same use. Pero what is the advantage of using dopamine? This is helpful if there is a requirement to raise the blood pressure. So, kung ang atuang patient na siya sudden nga heart failure, acute heart failure, tapos kailangan pag yun nato increase ang iyang blood pressure kay nagababa na iyang blood pressure, nagka-shock na the patient is experiencing shock. That's the time it's best to use dopamine. So again, the same mechanism of action, and then nganong helpful siya to raise the blood pressure because at higher doses class, it can also activate the alpha receptor. So mao na siya ang reason sa pagpataas sa blood pressure, especially the alpha-1 receptor that can lead to vasoconstriction, thereby increasing the blood pressure. Okay, so effects, there will be increased renal blood flow. This is actually a kidney protective na activity. Due to the raise in the blood pressure, there will be increase in the blood flow in the kidneys. And again, at higher doses, it can increase cardiac force and blood pressure. So clinical applications, acute decompensated heart failure, and then shock. By the way, wala man gud ay sa ako ang slide. Nato siya sa akong cellphone. Or kung maglisod kong pangita, ato na lang siyang i-search. Kasi board exam question ni siya. Lahi-lahi man gud na og effect si dopamine kadyot. Asa ba ko to gibutang? O na siya diri sa akong slide, wa ko kita. Wala na ko to siya gibutang sa akong slide man god. Wait lang ha, pangitaw na to. Sulat na ko ha. This is for the doses. Ay, ayan. Ayan, this one. Kay board exam question ni siya class. These are the effects of dopamine depende sa iyahang dose. So at 1 to 5 micrograms per kilograms per minute, or we call this the low dose, the effect will be on the kidneys. At low dose class, ang trabaho ni dopamine is to increase urine output and renal blood flow. Ayan. Now, at medium dose, that is between 5 to 15 micrograms per kilogram per minute. Kaya remember, dopamine is given IV. So, we call this the medium dose. The activity of the dopamine is on the heart. Okay? Sa heart na iyang effect, meaning there is increased cardiac output. CO is cardiac output ha. Okay, there will be increase in heart rate and increase in contractility, meaning there is positive inotropic na activity. And lastly, we have the high dose 20 to 50 micrograms per kilogram per minute. This is the high dose here. The effect will be in the blood vessels. This is the time there will be constriction. There will be constriction, and this will result in the increase in blood pressure. So those are the effects of the dopamine class. Depende sa iyahang dose. Depende sa dose nga gigamit. Questions? Wala. So let us continue. Clinical applications, syempre for heart failure, especially when there is cardiac arrest, sudden cardiac arrest, and then for shock. When you say shock class, the patient will experience sudden drop sa iyahang blood pressure. And remember, pag ipataas na tong dose ni dopamine, it can cause vasoconstriction. Toxicity, still arrhythmia. Our positive inotropic drugs can really cause arrhythmia. Taas manggod ang heart rate. And just like dobutamine, this is also an additive sa ato ang mga sympathomimetic drugs. Okay? Questions? Sa ato, mo lang to class ang atong mga inotropic drugs. Meaning mga drugs na to that will increase the contractility of the heart. Walay pangutana, nasabtan ba to? Or naay na-confuse sa unsa ba? Wala man, no? So mag-move on ta. Let's have the drugs without positive inotropic effect pero ginagamit gihapon for heart failure. Again, these next sets of drugs don't have effect directly on the heart. Wala sila positive inotropic na activity, but again, ginagamit for heart failure. And take note, this is our first line therapies for chronic heart failure. I told you digoxin is a mainstay. It's a maintenance drug for heart failure, but our first line therapy for chronic heart failure are these drugs that don't have positive inotropic effect. Mo ni ang pinakaunang ginahatag if the patient is diagnosed with chronic heart failure. And what are those? You are very familiar with these drugs, the diuretics, the ACE inhibitors, ARBs, aldosterone antagonists, and the beta blockers. So ato silang isa-isahon. So, we have here diuretics and vasodilators are very important for acute heart failure. If there is like sudden nga cardiac arrest, kailangan na siya, ginahatagan na siya og either vasodilators to dilate the blood vessels in the body and thus may efficient blood flow, especially nga ang heart hinay na siya mo pump. And diuretics to decrease the blood volume. So, kuhaan og tubig glass ang patient with heart failure. Kay kung daghan iyang tubig, daghan pud na ang iyahang blood, and that will be difficult for the heart to pump kung daghan kayo ang blood niya. At the same time, mutaas pa jud ang blood pressure. So, musamot og kaguba ang heart. Thus, the mainstay, another maintenance for heart failure management, kaya ang ato ang mga diuretics. So remember ha, si diuretic, wala siya positive inotropic activity, wala siya direct effect on the heart, pero it's a maintenance drug. This is just to eliminate too much water in the body so that dili mo daghan ang blood, so mag-reduce ang pressure, mag-reduce pud ang preload. Ang preload katong pagsulod sa dugo sa heart, mag-reduce siya kay mag-reduce man ang blood volume. So mo na ang akong father dati before siya namatay no kay nagainom pud to siya og duha ka klaseng diuretics. The first one is the spironolactone, the other one is furosemide. So kailangan man gud niya kailangan niya magbawas og tubig sa iyahang lawas. Unya at the same time no nagainom to siya og diuretics pero limited pud iyahang tubig. So di ba kita ato ang requirement is 2 liters lang per day. Tapos kato siya akong papa kay 1 liter per day lang yun ang iyahang dapat mainom. Tanan klaseng fluid na siya, dili lang siya water. Apil na kung magkape siya, kung inom siya juice, magsudan siya og kanang sabaw, apil na sa counting dito sa 1 liter. Kay tungod hinay mo contract iyang heart, dali magtapok ang tubig sa iyang body, mag-edema man siya dayon. So mudako dayon ang iyang tiil and like other parts sa body, pati iyang diri sa iyang nawong kay makita nimo na nag-edema na apil dinhi pag masubraan siya water. So muna mainstay sa heart failure ang diuretics. So ang ginagamit, we have here spironolactone or eplerenone. Kana silang duha, di ba? They are potassium sparing diuretics pero they are also called aldosterone antagonist na diuretics because of their antagonistic activity kay aldosterone. Si aldosterone is produced by the kidneys. Ang effect nila kay magkaroon og water and sodium retention inside the body mo na nga gina-antagonize siya. And mostly for heart failure, our combination drug is either aldosterone antagonist na diuretics plus the ACE inhibitors. So pag i-partner na sila class, there is additional benefit of decreasing morbidity and mortality. So as far as I can remember, ang akong papanana siya spironolactone, napag yun na siya enalapril. So ang tao nga na heart failure class, mostly polypharmacy yun na siya. Na siya digoxin, may spironolactone, napay enalapril. And then daghan pa nga drugs ang sunod. Kay tungod chronic use, napamanggod siya furosemide. So napa siya furosemide, and then chronic use of this drug can lead to increase in the uric acid. So gitagaan na po siya tambal for gout. So mo na nga nagrabe na gyud ang polypharmacy. So remember ha, aldosterone is produced by the adrenal medulla, and then it can cause water and sodium retention. That is why magka-problema ka when it comes to the blood pressure. It can cause myocardial and vascular fibrosis and dysfunction of the postural baroreflex or baroreceptor. So you know this, agian lang nato ha, loop diuretics, you can use this for people with heart failure. The same drugs, kung sa itong ginagamit kay hypertension, maupod ang sa heart failure. So ang tandaan lang nato as dapit, syempre pag loop diuretics sa thick ascending limb of the loop of Henle. The same effect with that of the hypertensive na action, mag-increase ang excretion ni salt and ni water, mag-decrease class ang volume sa blood, so definitely mag-decrease ang preload and ang afterload. And for patients experiencing edema because of the low contractility of the heart, pwede po siya mag-reduce sa water accumulation. So therefore, we can use this for severe hypertension, but we can also use this for both acute and chronic heart failure, or syempre sa mga edematous conditions. Kaya lang ang toxicity, the same toxicity with that sa hypertension. So dili na kayo na ko siya i-explain thoroughly ha, kay nahuman na tani dugay kay ta nahuman sa hypertension pila ka weeks na to gi-istoryahan. The same lang man gihapon ang ilahang toxicity, the same mechanism of action, pero pwede gamiton sa both conditions. So na-mention na nako ni that loop diuretics are similar to sulfonamide. So naa sila'y sulfur, thus na ay skin conditions nga effect. The thiazide diuretics also can be used for heart failure. Example, the hydrochlorothiazide. But you can also use the other thiazide diuretics. So asa gani nga part sa nephron nag-act si thiazide diuretic? Unsa nga part? Sa kung si loop of Henle kay sa peak ascending loop of Henle, si thiazide asa dapit na nephron, nakalimot na. Very good, Belly. And Sarah, that's the DCT, distal convoluted tubule. The same effect with that of the furosemide but less efficacious. The same use. Hypertension, chronic heart failure, and hypercalciuria. Because thiazide diuretics can also increase the elimination or excretion of calcium. So take note of the toxicity ha, hyperglu, hyperglycemia, hyperlipidemia, hyperuricemia. And just like loop diuretics, ano po ni sila? Derivative of sulfonamide, so it can cause sulfonamide allergy or skin conditions also. And then we have aldosterone antagonist. We only have two here, spironolactone and eplerenone. So di ba ang tawag nato ani sa ilaha kay potassium sparing diuretics, pero kauban nila si triamterene and amiloride. Pero kung aldosterone lang yun class ang atong purpose, duha lang na sila, si spironolactone and si eplerenone. So do not forget, ang part sa nephron kung asa nag-act ning atong aldosterone antagonist sa collecting duct, or we call it collecting tubules. The same effect with that na na-discuss nato sa hypertension. So I hope class, if you have time, parehas sa Sabado, wala man mo'y klase sa inyong hospital internship sa Sabado, no? If you have time, you can review the lecture para masulod yun sa inyong memory ang atuang mga gipang discuss kay the same drugs lang man ni sila. Dito lang ko nag-take time sa mga lahi nga drug like sa digoxin. Yeah, the same use pag yun, chronic heart failure, hypertension, and since this is class and aldosterone antagonist, so pwede na to siya i-treat for aldosteronism. These are cases class na mutaas ang aldosterone in the body. Bakit wala kayong pasok? Wala man natay schedule sa September. Nabay gibutang nga schedule? Di ba gitagaan mo og schedule ni Mama Be? Nagingon siya nga nabay klase sa Sabado. Kaya mostly ako man ang nag-handle og Sabado, pero wala, dili man ko available sa Sabado. So, ato lang na isang i-confirm kay Mama Be kung magklase ba mo or basig mag-exam mo. Basig mag-exam mo. Kana dayang ako ang wala naisip kasi mag-exam mo ug una-una sa inyong internship. So toxicity, since these are potassium sparing diuretics, so syempre makataas siya og potassium level. And anti-androgen action. This is androgen ha. Unsa gani ang adverse effect ni spironolactone class? What do we call that? Na anti-androgen action. Anti-androgen. That's the male hormone. Isang well-known nga adverse effect ni spironolactone only, walay appeal si eplerenone. So ito. Unsa to siya? Wala na ko gi-specify din ha, pero unsa to siya para sa spironolactone nga adverse effect. Nakalimtan na, manawag ta og taw basig natug na mo dira. Atong pangutan-on si kinsa wa nagatingog diri. Movie na. What is again the anti-androgen nga effect ni spironolactone? Adverse effect ni spironolactone, pinaka-common. What was that again? No, anti-androgen. I'm talking about the anti-androgen, meaning anti-male hormone. nga activity ni spironolactone. So duha man ni sila class nga aldosterone antagonist. Pero si spironolactone lang ang naay. Yes, tama na siya, Claire. Og belly gynecomastia. So do not forget that. Pag maingon kay kag anti-androgen actions na toxicity, we are referring to gynecomastia, but only the spironolactone has this kind of effect. So do not forget that. Now, let's talk about the ACE inhibitors because after the diuretics, the next drug that will be very helpful for patients with heart failure is the ACE inhibitors. So si ACE inhibitors, klaro na siya, mechanism of action, inhibits the ACE enzyme, the angiotensin converting enzyme. Para katong sa pathway nato sa RAAS class, dili na ma-convert si angiotensin 1 into angiotensin 2. Kaya si angiotensin 2 can cause vasoconstriction and can cause water and sodium retention. So kung ihatag nato na siya kay sa patient class with heart failure, maka-help na para dili pud mutaas ilang BP, dili pud mag-constrict ilang mga blood vessels na maglisod samot ang heart sa iyahang trabaho, and at the same time mag-reduce pag yun ang water and salt retention. So mag-reduce ang blood volume, mag-reduce ang preload. So dili malisdan ang heart og pump og daghan kaayo nga blood. Mao na ang activity sa ato ang mga ACE inhibitors. So again, ibaba ang level ni angiotensin 2 and napo na siya effect na maka-reduce og sympathetic activity kay the presence of angiotensin 1 class will also reduce the release of norepinephrine. Kaya pag daghan pud ta kayog norepinephrine, syempre remember the alpha-1 receptor will cause vasoconstriction and the beta receptor can cause increase in heart rate. Pero that will be a problem class for the patient with heart failure pag nag-tachycardia siya, perme. So mechanism of action, you know this very well, inhibits the ACE enzyme para dili ma-convert si angiotensin 1 to angiotensin 2. So ang effects na mention na nako, no vasoconstriction, so definitely there is dilation. There is reduction of the aldosterone secretion, so walay retention sa water o sa sodium. There is increased output sa heart and then reduce cardiac remodeling para dili mag-cause og cardiomegaly. So, kano sa nato gamiton si ACE inhibitors? Chronic heart failure, syempre, we are done with hypertension. And katong akong assignment sa inyo, ano gani ginagamit si ACE inhibitor para sa patient with diabetes even though walay hypertension. Ano sa inyong na-research ato? Let's see. Anyone? Ano sa na-research ninyo atong assignment ninyo? Why do we use ACE inhibitors in patients, in diabetic patients, even they don't have hypertension? Ano sa reason inyong nakita? ACE inhibitors can be prescribed in individuals with diabetes mellitus even if they don't have hypertension because they have been reported to improve kidney, heart, and to a lesser extent, eye and peripheral nerve function of patients with diabetes mellitus. So these favorable effects are the result of inhibition of hemodynamic and tissue effects of angiotensin 2. Okay, so si angiotensin 2 manggod, grabe iyahang effect when it comes to like blood vessels. There is vasoconstriction, aldosterone level causing water and sodium retention, and that will lead to problems sa kidneys manggod. So muna nga naka-specify din diabetic renal disease. So to protect the kidneys class of the patients with diabetes, that is the reason why we use ACE inhibitors. Okay? So tama na siya din Majed, nga nakabutang organ protective effect. It will cause dilation. So ang blood flow, for example, ang blood flow sa kidneys will be efficient. So that is the reason why. Not just with the kidneys, but that is also true for other organs. Makaprotect po siya kay the problem, di ba, with diabetes is daghan sugar sa blood, making it viscous and magka-problema ta with the blood flow na hangtod magkalisod og function ang kidneys, for example. So to dilate the blood vessels to accommodate the viscous blood, ano siya ang reason din ha ginagamit nato si ACE inhibitor. So tama na siya inyuhang na research. But our problem with the ACE inhibitors, the dry cough. Aside from the hyperkalemia and the angioneurotic edema, the dry cough gyud ang atuang problem. So if dili na siya ma-tolerate sa patient, that's the time the doctor will shift to the ARBs. So do not forget ha, pag ACE inhibitor ang ending kay pril, captopril, enalapril, and so on. They are mostly prodrugs except for captopril. Now, si angiotensin 2 receptor blockers or the ARBs mo ni ang nag-end sa sartan. So they have the same activity with that of the ACE inhibitors pero limited ang beneficial effect ni ARBs. Again, limited ang beneficial effect ni ARBs. Unlike sa ACE inhibitors, the ARBs don't have protective activity sa organs. So muna nga ang atuagong yung gusto is the ACE inhibitors, kaya lang ang dry cough ato ang problema. So again, this should be considered in patients intolerant of ACE inhibitors, incessant cough. So most of the time, either candesartan or losartan ang ginagamit. So syempre, mechanism of action, inhibition of the angiotensin receptor. Munang ARBs, angiotensin 2 receptor blocker. The same effect with the ACE-I and ginagamit lang if the patient cannot tolerate the cough caused by the ACE inhibitors. The same toxicity, this can lead to the increase of potassium inside the body. Dili siya ma-excrete and there will be angioneurotic edema. Meron siyang mga hives na mga rashes sa body. Ano ang iyahang effect. Pero walay dry cough. Now, natriuretic peptides. So these are approved for use in acute, take note, acute heart failure. Example of natriuretic peptide is the nesiritide. Brand name in the market is Natricor. Now, sa pangalan palang class, natriuretic. Natri is referring to sodium, uretic is urine. Meaning, by using this drugs class, we can increase the elimination or excretion of sodium via the urine. Manang gitawag siya natriuretic peptide. So mechanism of action, this activates the BNP or the brain natriuretic peptide receptor. So nagyud ta inside our body, especially sa brain, the natriuretic peptide receptor na kung ma-activate na siya, that will trigger the body to excrete more sodium via the urine again. And it will also cause increase sa CGMP. Class, lahi ang CGMP sa PCOL, lahi ang sa MANOF. Ang CGMP sa PCOL, it is cyclic guanosine monophosphate. Again, that's cyclic guanosine monophosphate. Ang sa MANOF class, ang CGMP is current good manufacturing practices. Dire CGMP na siya and ang activity ani nga substance inside the body is mag-reduce siya venous and arteriolar tone, which means mag-dilate siya sa blood vessel. Mo na ang ginamin niya, mag-dilate sa blood vessel. Kanang reduces venous and arteriolar tone. So, syempre, effect, vasodilation, and at the same time, diuresis kay natriuretic peptide man. And asa na to ginagamit for acute decompensated heart failure. Acute ha, kanang sudden nga cardiac arrest. Okay? The problem is renal damage because the kidneys will work hard for this just to eliminate more sodium and more water. And since there is vasodilation, syempre, there will be hypotension if masobrahan. Now, we have atrial natriuretic peptide. Actually, parehas lang niya siya. Ang katulang isa kagain na brain. This one is on the heart. Pero that's the same goal to eliminate sodium and water also. So we have here ANP. The name of the drug is the peritide. And we have the urodilatin, or the name of the drug, DIURETICS. Okay? And then other drugs that can be used for heart failure, we have the bosentan, brand name na niyang Tracleer ha, and the tezosentan. They are active competitive inhibitor of our endothelin. So remember, this endothelin is produced by our body, and ang main activity na niya is vasoconstriction. So if this substance produced by our body binds to its receptor, syempre mo ni siyang gawas. Therefore, we inhibit it. And the drugs used to inhibit endothelin in the body are the bosentan and the tezosentan. But they are not common drugs. Even in my internship or my experience of pharmacy, wala pa ko kitag bosentan and tezosentan. So this is seldom used na drug. So aside from the activity of vasodilator sa hypertension, they are also very useful for heart failure. So nga naman, mo dilate man ang mga blood vessels, so it may reduce preload through venodilation or reduction in afterload through arteriolar dilation, or both. Pwedeng duha, veins and arteries. So we have here, I don't know if you are familiar with the isosorbide dinitrate, or we call this as ISDN in the market. This is venodilator class, and ang mechanism of action is kabaliktaran sa bosentan o sa tezosentan. We have two substances released by the body, the endothelin and the what's the other one? Nitric oxide, the nitric oxide. Pero baliktad na silang activity. This one constricts the blood vessel and this one dilates the blood vessel. So this one is being inhibited, but this one is gina-trigger na to ang iyahang release. So just like the isosorbide dinitrate, it can trigger the release of the nitric oxide, and also activates the guanylyl cyclase that is also used to produce the CGMP, that is a vasodilator gihapon. So again, this is the enzyme used to produce the cyclic guanosine monophosphate, which is also a vasodilator. Pero ISDN is just a venodilator, meaning it will just dilate the veins. So unsa ang brand name ni ISDN in the market? Anyone who knows the brand name ni ISDN? I forgot ang pinakasikat. Isordil. Isordil. Are you familiar with Isordil? Or this is the first time you heard of this drug? Muna siyang pirmi na ko makita sa Facebook na mga memes. Kay mo na tong loose tablets nga gamay kaayo nga color pink class. Gamay jud siya kaayo, mas gamay pa siya sa sa digoxin. So siguro mga ingani lang siya kagamay. And then na siya score sa tunga. Color pink ni siya. And then this is given sublingual. So how do you take sublingual na tablet? It should be placed under the tongue. So ano siya, yung brand name, Isordil. Pinakasikat nga brand name sa ISDN. So syempre again effects, there will be dilation of the blood vessel, and there will be reduction of the preload because of the stretching of the veins. So when do we use our ISDN? This is used for acute and chronic heart failure. and also sa angina. So, pag mag-discuss na taog sublingual, nabasa mo ko sa chat ni Tin nga sublingual. Pag mag-discuss na taog angina class, we will have a deeper understanding of the ISDN. Okay? Now, toxicity. Syempre, because of the dilation, there will be hypotension, and there will be tachycardia. Class, pag ang patient nagababa ang BP, always good na siya nga ang body's response is increased heart rate. And take note of this, headache. Because of the vasodilation, there will be headache. This is a board exam question. So muna nga, naka-bold. And then hydralazine is another one. We know this one na oral vasodilator siya. It can also increase the production of the nitric acid, but this one, unlike the ISDN, this is an arteriolar dilator. Effects, syempre vasodilation, thus there will be reduction in the blood pressure, the afterload of the heart, pero there will be increased cardiac output because the heart will be efficient kapag ka gamay lang na blood ang iyahang ang masulod and makaproduce siya og ano sa tawagan na kanang efficient ang iyahang pagpump. That's what I mean with cardiac output. So we know also that ang board exam question for hydralazine when it comes to toxicity is the SLE-like symptoms. Katong murag malar rashes, examples sa nawong, murag na ay lupus. Now si nitroprusside, ang both arteries and venodilator, but this is freshly prepared plus kasi dali siya maguba sa light. But this one also increase the release of nitric oxide and also activate this enzyme just like the ISDN. So effect, syempre there is marked vasodilation kay both arteries and veins yun to. But there will be reduction in the preload and afterload of the heart when it comes to the amount of blood that enters the heart. Thus, it can also be used for acute cardiac decompensation aside from sa hypertensive emergencies na na-discuss na nato. Other name for hypertensive emergencies, we have malignant hypertension. Questions so far? Anyone nga na-confuse sa atong mga itong istoryahan kay murag daghan kay atong tambal? So there will be excessive hypotension ha, and take note that nitroprusside contains cyanide, so it can cause cyanide toxicity. And then I think this will be, if I'm not mistaken, this will be the last one, beta adrenoceptor blocker, syempre atong mga olol. So mechanism of action blocks the beta-1 receptor. So ako lang i-discuss nga naman ginagamit si beta blockers for heart failure nga mag-block man siya kagaina si beta stimulant or beta katong dopamine and dobutamine mga agonist gamiton siya sa heart failure. Tas karon si beta blocker gamiton po siya sa heart failure. Si dopamine ug si dobutamine plus ginagamit sila for acute nga heart failure kana mo kalit og cardiac arrest para mo pump ulit ang blood, pero si beta blocker ginagamit siya as maintenance. So nga naman, this is used to slow down the heart. Kasi remember, people with heart failure always have tachycardia. Pirmi na sila paspas og heart rate kay tungod kulang ang oxygen sa body. Ang response sa body nato is mag-release og daghang norepinephrine para papaspason ang activity sa heart. And then sige silag tachycardia hangtod nga mauwi nga mosamot og kaguba ilang heart due to excessive activity. So dinha mo sulod ang trabaho ni beta blockers to slow down the heart class. So aside from the reduction of the blood pressure, which we have already discussed already, the effect is to slow down the heart. Now toxicity, we know this especially if non-selective, it can cause bronchospasm o na di siya pwede ihatag sa na ay asthma. Syempre, there will be bradycardia, atrioventricular block. This will cause arrhythmia class kay tungod gipa-slow down nimo ang heart. Ang conduction system dili na siya magsabay with the electricity. And acute cardiac decompensation. Kay tungod gipa-slow down ang heart, syempre mag-slow down pud ang
pag-pump niya og oxygen sa body. So it can also be its side effect. So the effect can be the side effect. So humanon lang nako ni 4 stages of heart failure development. Again, these are patients with heart failure. Stage A, if the patient is at risk of having heart failure. At risk pa lang, wala pa'y sakit. No signs, no symptoms. Pero at risk, paano ka makaingon og at risk? Number 1, pwede nga naa siya'y hypertension. Number 2, pwede taas iyang cholesterol. Number 3, pwede nga naa siya'y atherosclerotic plaque. Ug number 4, genetics. Nasa linya sa inyong pamilya. So stage A na. No disease yet, no signs and symptoms, pero at risk. Pag stage B, there is evidence of structural heart disease but no symptoms of heart failure. Wala pa'y signs and symptoms. Wala pa'y symptoms, wala pa siya naglisod og ginhawa, wala pa siya nagatakicardia, pero pag i-check last, paghabot sa x-ray, makita na dito nga, uy, murag enlarge iyang heart. So there is structural evidence sa heart disease. That's stage B. And stage C, if the patient has structural heart disease and at the same time, naanay signs and symptoms nga naagid siya heart failure. Pero the good thing here is responsive pa siya to ordinary therapy. So kung hatagan siya digoxin, hatagan siya og beta blockers, responsive ato ang patient. Mupatong na siya sa stage D class kapag ka dili na ang patient mag-respond to ordinary treatment. So mauna ni siya ang naga-require og mga surgery, open heart surgery, kung bypass, mga angioplasty na mga himuon sa heart para magkaroon lang yun og intervention or even transplant. Kasi again, dili na responsive ang patient to drug therapy nato. Now, class 1. This one is the stages ha. Ang classes is depende kung makatungtong na class o stage C ang patient. That's the time we classify whether class 1 to class 4 ato ang patient. Ang class 1, no limitations on ordinary activities and ang symptoms mag-occur lang pag greater than ordinary exercise. Class 1, na siya sakit, stage C man, so na siya signs and symptoms sa heart failure. So naanagid siya sakit nga heart failure. Pero makita lang nimo ang symptoms pag excessive na iyahang ginahimo nga activity. Example, excessive na exercise, excessive na physical workload. And then class 2, if there is slight limitation of ordinary activities na mag-result sa fatigue and palpitations with ordinary physical activity. Example, nanilhig siya. Pagkahuman niya silhig, ihapo na siya, nag-fatigue na and nag-palpitation. So slight limitation na sa mga ordinary activities. And then class 3, if failure results in no symptoms at rest, so kung at rest lang siya, naghigda lang siya, wala siya gibati, walay fatigue, walay hapo, walay tachycardia. Pero kung less than ordinary nga exercise yung gihimo, gitindog lang siya, gikan sa kusina, niadto siya sa sala, naghapo na siya, class 3 na siya. Less than ordinary exercise. And class 4, if even the patient is at rest, na siya symptoms. So mauna siya class ang mga classification of our heart failure. So nahuman din ako ang akong lesson tabang mga langit. We will have a separate na schedule for our quiz. Any questions so far?